Pediatric history taking. The complete history is necessary and it leads to the correct diagnosis in the vast majority of children. Usually is obtained from the parent, the older child, or the caretaker of a sick child. A short, rapidly obtained history of the events of the immediate past may suffice temporarily, but as soon as the crisis is controlled, a more complete history is necessary. A convenient method of learning to obtain a meaningful history is to ask systematically and directly. During the interview, it is important to convey to the parent interest in the child as well as the illness. Allow the parent or the caretaker to talk freely at first and to express the concern in his or her own words. This interviewer should look directly either at the parent or the child intermittently and not only at the writing instruments. A sympathetic listener who addresses a parent and child by name frequently obtains more accurate information than does a harried, distracted interviewer. Careful observation during the interview frequently uncovers the stresses and concerns that otherwise are not apparent. General information, like we should identify the data, like date of interview, name, age, birth date, and sex. Referral source if pertinent, relationship of the child and the informant. And we should note the contacts also, like address and the telephone number of the informant. In case of chief complaint, even in the given in the informant's or patient's own words, the chief complaint is a brief statement of the reason why the patient was brought to be seen. It is not unusual that the stated complaint is not the true reason the child was brought for the attention. Expanding the question of why did you bring him to what concerns you allows the informant to focus on the complaint more accurately. History of present illness. Details of the present illness are recorded in the chronological order. For the sick child, it is helpful to begin the child was apparently well until X, that is the number of days before the visit. This is followed by the daily documentation of events leading up to the present time, including signs and symptoms and the treatment if any. Statements should be recorded in the number of days before the visit. Address the information about the system that were not touched in the history of a present illness. This should be done systematically to avoid the omissions. Questions concerning each system may be introduced with the questions such as, are there any symptoms related to? In the past medical history. In case of prenatal history, questions to be answered include those regarding the health of the mother during this pregnancy, the number of previous pregnancies and their results, radiograph or the medications taken during the pregnancy, results of serology and the blood typing of the mother and baby. If the mother's weight gain has been excessive or the insufficient, this also should be noted. Birth or the natal history. The duration of the pregnancy, the ease or the difficulty of a labor and the duration of a labor may be important. The type of delivery, like spontaneous, forceps assisted or the cesarean section. Type of anesthesia or the analgesia used during the delivery and presenting part, if known or recorded. Note the child's birth order if there have been multiple births and birth weight. Postnatal history. Many informants are aware of the APGA scores at birth and at 5 minutes, any unusual appearance of the child, such as cyanosis of the respiratory distress and any resective efforts that took place and their duration. If the mother was delayed in seeing the infant after the birth, reason should be sought. The type of onset of any abnormal states may be significant. The history of each past illness should include the onset, duration, course, and the termination. If the hospitalization or the surgery was necessary, the diagnosis dates and the name of the hospital should be included. Questions concerning the allergies, including the any drug reaction, food allergies, hay fever, and the asthma should be noted. Accidents, injuries, and the poisoning should be noted. Feeding history. Note whether the baby was breast or bottle fed and how well the baby took the first breeding. If the infant has been bottle fed, inquire about the type of formula used and the amount taken during the 24-hour period. Determine the ages at which the solid foods were introduced under supplementation. Example with the vitamins took place as well as the age at which the weaning occurred and the method used to wean. Developmental history. Estimation of the physical growth rate is important. Attempt to ascertain the birth weight, subsequent weight and the length are desirable. Any sudden gain or loss in the physical growth should be noted particularly because its onset may correspond to the onset of organic or the physiosocial illness. In case of the developmental history, it may be helpful to compare the child's growth with the rate of growth of siblings. Ages at which the major developmental milestones were met aid in indicating the deviation from normal. Ages of dressing self, tying own shoes, hopping, skipping, and riding a tricycle and bicycle should be noted, as well as a grade in school and the school performance. Immunization history. The types of immunization received with the number, date, size given, and the reaction should be recorded as part of the history. Determine the missed opportunity or need for the booster immunization. The family history provides evidence for the considering the familial diseases as well as the infections or the contagious illness. A genetic type chart, which is easy to read and very helpful. It should include the parents, siblings, and the grandparents with the ages, health, or the cause of death. If the genetic type chart is used, pregnancy should be listed and should include the health of the siblings. Pediatric chart. In the circle, female, square, male. In the pediatric chart is given maternal grandmother 67 years old, living and well. Paternal grandmother 66 years old, living and well. In case of second choice, maternal grandfather died at 62 of a heart disease. Paternal grandfather 71, living and well. The single horizontal line married. In the double horizontal line, consanguineous marriage. Mother 39 years old, living diabetic. Father 41 years old, living hypertensive. Stillbirth 1968. X is died. Male sibling 14 years old, living and they have a hay fever. Patient with 12 years old and a brother who has 10 years old, living and well. Female died at 2 days old of respiratory diseases. The family history and the social history of a patient. Details of the family unit should include the number of people in the habitat and its size, the marital status of the parents, significant caretaker, and the total family income and its source. Sometimes it may be necessary to interview the other parent. In case of physical examination, the examination of the infant and the young child begins with observing him or her and establishing the rapport. The order of the examination should fit the child and the circumstances. It is wise to make no sudden movements and to complete those parts of the examination that require the child's cooperation. Painful or the disagreeable procedure should be deferred to the end of the examination, and this should be explained to the child before proceeding. For the older child and the adolescent, the examination can begin with the head and conclude with the extremities. The approach should be gentle but explorations and complete. For the child, communication frequently permits an orderly examination. Some children are best held by the parent during the examination. For others, the part of the examination may require the restraint by the parent or the assistant. When the complaint includes a report of a pain in the certain area, this area should be examined last. If the child has obvious deformities, that area should be examined in the routine fashion without undue emphasis because the extra attention may increase the embarrassment or the guilt. In case of the physical examination, only the part that is being examined needs to be uncovered and then it can be reclothed. Except during the infancy, modesty should be respected and the child should be kept as comfortable as possible. With practice, the examination of a child can be completed quickly even in the most critical emergency states. Only in those with apnea, shock, absence of pulse, or occasionally seizures is the complete examination delayed. Although the method of procedure may vary, the record of examination should be in the same format for all children. This provides a easy access to the needed information later. Vital signs, temperature, these are measured from the axilla or rectum. Pulse rate can be obtained at any peripheral pulse, femoral, radial, or carotid. The normal rate varies from 70 to 170 beats per minute at birth, 120 to 140 shortly after the birth, and ranges from 80 to 140 at 1 to 2 years, from 80 to 120 at 3 years, from 70 to 115 after 3 years. and the respiratory rate should be determined by counting while observing the movement of the chest for complete 1 minute. Blood pressure should be measured with a cuff with the blade completely encircling the extremity and the width covering 1/2 to 2/3 of the length of the upper arm or upper leg. Anthropometric measurements. These include length, height, weight, head circumference. To obtain the height and weight recording, measure the infant supine up to the age of 2 years and standing thereafter. Measure head circumference in all infants less than 2 years of age and those with the misshapen heads. In case of general appearance, a statement should be recorded about the alertness, distress, general development, and the nutrition of a child. Mental status, activity, unusual positions, apprehensions, or the cooperativeness may direct the one to consider an acute or the chronic illness or no illness at all. The child who lies quietly staring into space may be gravely ill. Assessment and the treatment in the emergency triage. Emergency signs who requires the immediate emergency treatment. Priority signs should be given a priority so that they can be promptly be assessed and treated without delay. No emergency or the priority signs, no urgent cases. That is, can wait their turn for the assessment and the treatment. Emergency signs like triage of a patient involves looking for the signs of serious illness or injury. These emergency signs are connected to the airway, breathing, circulation, or consciousness, dehydration, and are easily remembered as ABCD. Each letter refers to the emergency signs, which, when the positive, should alert you to the patient who is seriously ill and needs the immediate assessment and the treatment. Emergency signs like ABCD. A. Look for the signs of serious illness relating to the airway, that is, the airway is open or not. B. Look for the breathing problem. Is there the visible difficulty in breathing? C. Look for the two sets of signs. First one relates to the circulation. Does the child have a fast beat? Second relates to the consciousness, that the child is in the coma, unconsciousness, or having the fit or the conclusion. Look for the signs of a severe dehydration. Does the child have the sunken eyes? Priority signs should alert you to the child who needs prompt but not emergency assessment. Severe wasting or the edema of both feet. Child is small, any sick child under the 2 months. Lethargy, continuously irritable and restless. Any respiratory distress. Pale burns, trauma, or other surgical condition. Check whether the child is hot or not. Child is in urgent referral and poisoning. Airway and breathing. Assess the airway. Is the airway obstructed? Always you must first open the airway. Manage a choking child. Manage the airway. Is trauma of a neck of possibility? Log roll. Stabilize the neck. Circulation and consciousness. Assess the circulation. Are the child's infant hands are warm? Is the capillary refill the time longer than 3 seconds? Is the pulse weak and fast? Assess the consciousness. Is the child in coma or in convulsing? Dehydration. Assess for the dehydration. Severe dehydration. Does the child have diarrhea, lethargy, and they have a sunken eyes? Does the child skin pinch go back very slowly, longer than 2 seconds? Systemic examination. Examine all systems thoroughly. Start with the system that is mostly affected. Examination should be systematic. Inspection, palpation, percussion, and auscultation should be head to toe. Thank you.